5 months old infant, large muscular VSD near the apex and follow has bidirectional, so ultimately indicating the right ventricular systolic pressure is very high. Because flow is bidirectional means for time being flow pressure within right ventricle becomes more than that of left ventricle. That is why flow is from left to right to left. Bidirectional means right to left and left to right, both flow are present within the VSD. So ultimately that indicates a raised right ventricular systolic pressure. Normally in the absence of pulmonary stenosis, raised right ventricular systolic pressure indicates raised pulmonary artery systolic pressure. That means raised pulmonary systolic pressure, raised mean pulmonary artery pressure and raised diastolic pressure also. So the only 5 months old infant having large VSD, the most likely scenario is because of large VSD, pulmonary vascular has got some changes due to which the right ventricular systolic pressure, pulmonary artery systolic pressure has become more. So it may be reversible and irreversible. If it is reversible, VSD closure is urgently suggested. If it has become irreversible, then even VSD closure will not give you any kind of relief. So ultimately it should be corrected as early as possible so that the pulmonary artery pressure is even raised will become normal if it is reversible. So you can calculate pulmonary vascular resistance. If pulmonary vascular resistance is low, that is reversible case. So that case after the closure of VSD pressure will become normal. If it is pulmonary vascular resistance is very high, in that case even the closure of VSD will not give you the good life to the child. That means the pressure will not become normal. So ultimately you see the global hypokinesia and D-shaped left ventricle. Because of VSD, the left ventricle has failed. You can see right atrium, right ventricle and main pulmonary artery are dilated. In case of large VSD, normally LV dilatation is seen. You see the VSD is with the severe PS. That is why RE, RV and main pulmonary artery dilated. This you can see the TRZ is very small, so RVSP cannot be calculated properly. If you calculate RVSP, it will be normally underestimated. Whatever you see, that will be less than what it should be. This is the pressure across or velocity across pulmonary valve, PRZ. So any velocity above the baseline is pulmonary registration jet, PRZ. So you see the peak velocity is 3.3 meter, peak gradient 44 millimeter of mercury. If you add this 44 to right atrial pressure, just take 15 millimeter of mercury, then that will be around 60 millimeter of mercury. 44 plus 15, close to 60. So ultimately severely raised mean pulmonary artery pressure. So pulmonary artery pressure, normal pulmonary artery pressure is less than 20. In this case, more than around 60. So you can see the highly raised mean pulmonary artery pressure. Obviously this case will also have highly raised pulmonary artery systolic pressure, highly raised pulmonary artery diastolic pressure also. Diastolic pressure you can see here from here. Just see, this is the velocity is 2.2 meter per second and peak gradient, so gradient at end diastolic velocity is 21 millimeter mercury. So whenever the velocity is more than 2 meter per second for the end diastolic velocity, it is likely that the child will have severely raised pulmonary artery pressure, severely raised pulmonary artery hypertension, severe pulmonary artery hypertension. So this is the cases of large VSD with severe pulmonary artery hypertension with global hypokinesia. Pulmonary artery hypertension may be reversible and irreversible. If pulmonary resistance is low, then it is reversible. If pulmonary resistance is high, then it is irreversible. So child should be operated as early as possible. If after the medical management, if the ejection fraction improves, only then. so that the pulmonary vascular resistance remains normal. Because initially what happens, severe pH with normal vascular resistance and severe pH with raised vascular resistance. So first initial scenario is severe hypertension with less vascular resistance. In that scenario, operation can be performed and prognosis is better. If severe pH with raised vascular resistance, then prognosis becomes worse. Child cannot be operated in that case. So VSD should be operated early so that the pulmonary vascular resistance does not become very high. That is the point. So whenever you see the VSD with bidirectional flow, you can suspect raised right ventricular systolic pressure, raised pulmonary artery systolic pressure, that is pulmonary artery hypertension. Then you should calculate pulmonary vascular resistance. That can also be calculated through with the help of TR-jet and acceleration time of RVOT velocity. In this case, as you see, the TR-jet is very trivial TR, so cannot be calculated exactly. So pulmonary vascular resistance through Doppler cannot be calculated exactly. We can calculate with the help of Doppler echo also at the same time with catheterization, also cath study also. In this case, likely chance is that vascular resistance will be very low because baby is only 5 months old. Only thing, after the correcting ejection fraction, the VSD has to be closed. Thank you.